Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing macronutrients, vitamins, and trace elements. The reason that we're talking about this topic today is that macronutrients and micronutrients are the building blocks of nutrition support. Each macronutrient and micronutrient has specific roles in the maintenance of the body. As a result of this, it's important to be aware of the functions of macronutrients and micronutrients, what their daily requirements are, and any toxicities and deficiencies related to macronutrients and micronutrients. Our objectives today will be to differentiate the terms macronutrient, micronutrient, vitamin, and trace element. We're going to list examples of macronutrients, vitamins, and trace elements, which will include, in some cases, trade names, as well as individual nutrients. We're also going to define functions, daily requirements, and then toxicities and deficiencies related to select macronutrients, vitamins, and trace elements, particularly with an emphasis on deficiencies. So just to start off, we're going to start off with some definitions. So macronutrients consist of protein, carbohydrates, and fat. Our micronutrients are much smaller molecules consisting of electrolytes, which are primarily elements, vitamins, and trace elements. So basically, between macronutrients and micronutrients, macronutrients are larger molecules, micronutrients are smaller molecules and elements. So that's how you essentially distinguish between the two. Macronutrients and micronutrients are mutually exclusive. One thing cannot be both a macronutrient and a micronutrient. Trace elements are minerals or elements required for virtually all aspects of metabolism. And they're typically found in small amounts, and that's why they are referred to as trace elements. In addition, vitamins are defined by the Aspen Core curriculum as essential organic substances needed in small amounts in the diet to maintain fundamental functions of the body, such as growth, metabolism, as well as cellular integrity. And there are many different vitamins, such as vitamin A, vitamin D, vitamin E, vitamin K, vitamin C, as well as the family of B vitamins, and we'll be discussing those today. So the first thing that we're going to start off with is macronutrients. So like I said earlier, macronutrients consist of protein, fat, and carbohydrates, essentially our larger molecules. Protein is also known as amino acids in nutrition terms. Fat is known as lipids, and carbohydrates are primarily dextrose, though there might be some other forms of carbohydrates that you might see, such as glycerol components or glycerin components, that might be potentially considered carbohydrates, depending on what your definition of carbohydrates is. But for our purposes, we're going to refer to carbohydrates as basically sugars or dextrose. The first macronutrient we're going to talk about is protein. So protein is basically built up of amino acids. If you remember back to your biochemistry classes, essentially amino acids are much smaller molecules in nature with essentially your amine and carboxylic acid groups at the end, as well as a specialized R group and a carbon in the middle. Whenever you link all of these groups together, you essentially form larger secondary, tertiary, or even quaternary proteins. In regards to protein that we actually administer to patients, we have many different formulations, both enterally as well as IV, that are available. As you see, we have a few different trade names or brand names of amino acid products that you will need to know that are bolded here. Some of examples of these are aminosin 2, travasol, clinosol, freamine 3, heptamine, and tropamine. These are IV formulations that are used primarily in the formulation of parenteral nutrition. In regards to protein, specifically in terms of function, protein is mainly known as the macronutrient that's responsible for the maintenance of lean muscle. So basically, if you think about bodybuilders and basically people who have larger muscles, a large part of why they may have larger muscles in addition to exercise may be actual protein intake. So essentially, protein is basically the building blocks that eventually lead to the development of muscle. In addition, proteins also function in many different ways in the body, such as enzymes. Most enzymes are actually proteins. They function as hormones. Another big important role of protein is that it actually helps in wound healing by basically having protein given to a patient in the body that will actually build up their immunity and speed up processes such as wound healing, might even fight infection if the patient is adequately nourished with protein. So, protein is a very important component to patients essentially maintaining healthy, non infected lifestyles. Another thing that protein is related to is gene transcription and translation. Proteins also function as buffers for acid-base balance and as well as for transportation and storage in the body. So one example of that is with ferritin in the body. One important note about protein whenever we start talking a little bit more about nutrition formulas is that protein provides 4 kilocalories per every 1 gram of protein. So if you have a patient who is receiving or intaking 100 grams of protein per day, each gram of that 100 grams is 4 kilocalories. So 100 grams in that case times 4 would result in 400 kilocalories total. Protein requirements vary depending on the different patient populations that exist out in um, practice. Typically, protein is estimated to provide about 20 to 25% of calories, but it may be higher or lower depending on what your individual patient's requirements actually are. So, this is not necessarily a hard and fast range. This is a range that you don't necessarily need to know off the top of your head, but it's just a range to kind of give you an idea about how much is actually consumed in our diets. In regards to protein requirements, healthy adults that are less than 60 years old or equal to 60 years old typically require about 1 gram per kilo per day of protein. And that range can range anywhere between 0.8 to 1.0 in most cases. Some patients may require slightly a little more, up to 1.2. But for the purposes of this class, we're going to refer to normal protein requirements as 0.8 to 1.0. This will be an important range to know. If you have a healthy adult who's not sick or critically ill that has an age greater than 60 years old, we correct that to 1.5 grams per kilo per day. And just a side note, in terms of these protein requirements, we base protein requirements based on primarily actual or ideal body weight, whichever is typically lower. Because ideally, whenever we give protein, we want to be feeding lean body muscle mass. We don't necessarily need to correct if the patient has an too much adequate amount of fat or anything like that. Basically, all we need to do is basically use either the actual body weight or the ideal body weight, whichever one is lower, particularly for healthy patients and critically ill patients with the BMI less than 30. For critically ill adults who do have a BMI less than 30, because they're critically ill and very hypercatabolic, their protein needs will go up significantly. So their protein requirements could be anywhere between 1.2 and 2.0. for a standard critically ill patient who, and our definition of critically ill in this case means intensive care unit or intensive care unit stay. So if they have been in a medical ICU, a surgical ICU, a cardiac care unit, a neuro ICU, etc., we are considering those patients critically ill. In patients who get continuous renal replacement therapy, which we'll talk a little bit more about later on in the course whenever we talk about nutrition and renal disease, because continuous renal replacement actually takes off a lot of protein from patients, that can actually increase the protein needs of a patient up to 2.5 grams per kilo per day. And again, that's based off of actual or ideal body weight. We don't tend to use adjusted body weight for nutrition calculations, just because it's not recommended per Aspen guidelines as being validated. Though it is debatable about using actual or ideal body weight itself for nutritional needs. The other requirements that you see below that are unbolded are for patients who are critically ill who have a BMI greater than 30. These are not numbers that you need to know off the top of your head, and if you do need them for an examination, for example, these will be provided to you. But for BMI between 30 and 40, it's 2 times ideal body weight of the patient. For critically ill patients who have a BMI greater than 40, in that case, it's 2.5 times ideal body weight. And for major burn injury, these patients actually require high amounts of protein as a result of the burn wounds that they have. These burns play a significant role in the immunity or lack of immunity in these patients. And that's why their protein needs are so much higher. Their needs actually are between 2.5 and 3.0 times actual body weight. So in regards to this slide, I want you to know the bolded values that are there. So healthy adults, less than 60, greater than 60, and critically ill. The unbolded values you will not need to know off the top of your head. The next macronutrient that we're going to talk about is fat. And these are essentially divided into essential fatty acids and non-essential fatty acids. Essential fatty acids are the ones that we actually have to obtain from the actual diet. Non-essential fatty acids are the ones that we make in our body. So things like linoleic acid and alpha linoleic acid, which you may hear about a little bit later on in the course, particularly whenever we talk about patients who are critically ill. Those are essential fatty acids, and we have to take them into the diet, or else we might develop a deficiency. Fat, in terms of what we provide it as, it can be either dietary lipids for enteral nutrition or as IV fat emulsion for parenteral nutrition. Some examples of the products that we commonly use for parenteral nutrition include intralipid. Particularly intralipid 20% is probably the most common percentage that you'll see out there. In this bag on the right that is white and milky actually will show you what intralipid actually looks like. SMOF lipid is another type of lipid formulation. Compared to intralipid, intralipid is a soy-based lipid formulation, or soybean based lipid formulation. In terms of SMOF lipid, the SMOF in SMOF lipid actually stands for the types of fat that are included within the lipid formulation. So S stands for soybean, M stands for MCT, or medium chain triglyceride, O stands for olive oil, and then F stands for fish oil. Propofol is actually another form of IV fat emulsion. It does provide fat calories. So if you have patients who are in a critical care unit who are receiving propofol for sedation, they will also be getting calories from that propofol. And in some cases, those calories may amount to over hundreds of calories per day just from propofol alone. And as a result, some patients who are on propofol might not actually require intralipid or small lipid supplementally to aid in their fat calories. Like I said earlier, lipid emulsion tends to appear milky white. The functions of fat in general include the formation of cellular membranes, as we have a lot of different phospholipids and other types of lipid that form our cells. So it's important for cellular development that we actually have fat in our diet. Fat is also involved in signal transduction pathways, particularly those relating to cytokines and the immune system, as well as gene expression. One caution for patients who get IV fat is that there may be a caution regarding patients who have egg allergies. And this only involves a certain part of the egg. In regards to the egg allergy, many patients do not have this type of allergy. And whenever I say allergy, I'm referring to an actual allergic reaction, such as anaphylaxis, shortness of breath, not necessarily an intolerance. If the patient has had a potentially lethal adverse reaction to eggs, it might be problematic for them to receive IV fat emulsion. And it depends on the product that you are administering to the patient. Please refer to the package inserts regarding each product regarding what they say about egg allergies, but I just wanted to put that little point in there. In regards to how much calories are provided by fat, it depends on what type of fat that we actually are giving the patient. In regards to dietary fat that we get in our diet provides 9 calories per every 1 gram of dietary fat. So for example, if we take in a snack or consume a snack that has 10 grams of dietary fat in it, then in that case, we will have received 90 calories from that dietary fat. In regards to fat emulsion differs from dietary fat in that fat emulsion provides 10 kilocalories per every gram of fat emulsion. The reason for this is because fat emulsion contains glycerol as an excipient as part of the formulation, which actually provides just slightly a little bit more calories per gram. Therefore, when we consider fat emulsion, we consider every gram of fat emulsion to have 10 kilocalories per every gram. So if you have a patient who's getting 100 grams of fat emulsion per day, in that case, they will actually be receiving 1,000 calories of fat emulsion. In regards to fat requirements, estimated daily provision of fat in the diet is about 10 to 35% of total calories, and this differs again depending on your specific patient. There's no absolute recommendation for the daily provision of enteral fat or even IV fat, other than the fact that for IV fat, the provision should not exceed maximums. And those maximums are important to know. Those are 2.5 grams per kilo per day for non-critically ill patients and 1 gram per kilo per day for critically ill patients. Typically, though, in a lot of institutions, we don't give typically more than 50 grams of fat per day, as can be seen in the intralipid bag on the right. The bag on the right is a 20% bag of intralipid that has 50 grams total of intralipid, or 50 grams total of lipid in it, which actually will result in 500 calories. Typically, in a lot of cases, we don't give more than that, other than if you may be doing a potential 3-in-1 formulation where the patient has a higher fat need. So for non-critically ill patients, we don't exceed 2.5 grams per kilo per day. And that number is reduced down to 1 gram per kilo per day for critically ill patients, because fat has been linked to infection risk and fungemia, which can be potentially lethal for any patient, but particularly for patients who are more vulnerable, such as critical care patients. The IV infusion rate for intravenous fat should be limited to 0.11 grams per kilo per hour. It's important to know when to hold IV fat emulsion for your patient. So examples of when you would not give IV fat emulsion would be, say, if your triglycerides are elevated, so greater than 400 or greater than 500. Different, text in the literature will say different things regarding that piece. In regards to the rest of the cholesterol panel, though, in terms of LDL, HDL, we typically really don't look at those as much, as those are not as acutely affected with the diet. Triglycerides are very much so more affected by just daily dietary intake. LDL and HDL are take chronic amounts of time to adjust. In addition, what I was alluding to before, if your patient has some type of infection or even sepsis, septic shock, for example, where that infection is causing the patient to become hemodynamically unstable or instable, and that can be defined as a mean arterial pressure of less than 65. And if you remember mean arterial pressure is calculated as 1/3 of systolic blood pressure and 2/3 of diastolic blood pressure. If you add those two together, you'll get a mean arterial pressure, or a MAP. If your MAP is less than 65 or your systolic blood pressure is less than 90, it may potentially be beneficial to hold IV fat emulsion, as fat emulsion in some studies has been linked to risk of infection, specifically fungemia. We'll talk about this criteria to hold fat emulsion a little bit more whenever we go into nutrition and critical care later on in the course. It is important to note that low provision of fat in the diet may result in essential fatty acid deficiency. So essentially our alpha linoleic and our linoleic acids are provided via intralipid. These fatty acids are not made in the body. And as a result, if you do not give fat to a patient, you risk the development of essential fatty acid deficiency. Clinically, this actually looks something along the lines in terms of physical presentation of potentially rash, dermatitis, sometimes thinning of the hair, or falling out of the hair may also occur. Typically, this doesn't happen, though, very often. Usually, it will take at least 2 weeks or more for essential fatty acid deficiency to develop. So very, in regards to the amount of times we'll hold fat emulsion, we can only hold fat emulsion for so long, even in our critically ill patients. And again, we'll talk about that later whenever we discuss nutrition and critical care. The last macronutrient we're going to talk about is carbohydrates. So in terms of IV formulations, these are typically provided as dextrose. And some examples of that are dextrose 5% in water, also known as D5, D10, D20, D30, D40, D50, and D70. I don't necessarily want you to memorize each of the numbers that are associated with the different dextrose concentrations. Even though all of these can be used in terms of the formulation of parenteral nutrition. I do want you to recognize, though, that the D obviously stands for dextrose, and dextrose is a carbohydrate. The functions of carbohydrates include our normal metabolic processes in the body, such as glycolysis, as you see on the right here, glycogenesis, ATP production, as well as obviously serum glucose maintenance, which is obviously important for all patients, particularly our patients who are either hypoglycemic or diabetic. So carbohydrates are essentially more or less kind of like the energy producing macronutrient, or one of the main energy producing macronutrients. As you see in the right, a little schematic of glycolysis, where essentially we net ATP and NADH, which eventually goes on to produce pyruvate, which eventually goes on to the Krebs cycle, which will produce even more energy. It's important to note for carbohydrates that carbs and dextrose particularly provide 3.4 kilocalories for every 1 gram of dextrose. So if you have 2 grams of dextrose, that is 6.8 kilocalories of actual calories. In regards to dextrose requirements for patients, these actually make up the majority of our total calories in our diet. So about 45 to 65% of total calories are made up of carbohydrates and dextrose. Whenever we dose parenteral nutrition in a couple of weeks, one thing that we're going to need to note is that the daily minimum requirement of dextrose for most patients to maintain normal function, particularly cerebral function, is 150 grams of dextrose per day, though that may alter depending on the size of your patient and other factors. In terms of parenteral nutrition, we typically start dextrose at 150 grams per day, or between 2 and 3 grams per kilo on day one, to prevent a syndrome called refeeding syndrome. And essentially, what refeeding syndrome is a syndrome that occurs in particularly patients who are malnourished, but it can really occur in anyone. What happens in refeeding syndrome is that because bodily processes of the patient that you're feeding may have not been as ramped up as they may have been compared to whenever they were normal. So maybe they weren't undergoing a lot of the different metabolic processes. What happens in refeeding syndrome is whenever you start feeding that starved patient again, they will actually start utilizing electrolytes that are in the body to come in and be used as cofactors in a lot of these different metabolic processes. And when that process occurs, the electrolytes are getting taken from the bloodstream. So electrolytes such as phosphorus, potassium, and magnesium are taken from the bloodstream and then essentially routed to all of these different metabolic processes, which actually can cause hypophosphatemia, hypokalemia, and hypomagnesemia, which we'll discuss a little bit more whenever we talk about enteral and parenteral nutrition. For parenteral nutrition, we typically titrate by about 100 grams per day as tolerated per goal to minimize the risk of refeeding syndrome. Our daily requirement of dextrose typically does not exceed an infusion rate of greater than 5 milligrams per kilo per minute, though that number varies in the literature anywhere between 4 and 7 for the most part. And dextrose requirements are usually calculated last whenever we're writing a parenteral nutrition formula. Typically what we'll do is we'll calculate protein first, and then in conjunction with fat, we will calculate the dextrose or carbohydrate requirement. Another thing that's important to understand regarding macronutrients is how to calculate energy expenditure. And energy expenditure consists of a few different components. It consists of our basal energy expenditure, essentially the energy that we burn just sitting normally without doing any extra activity. It consists of any diet-induced thermogenesis that occurs. So anytime that we take in food in our diet, that actually will, utilize some energy as well, about 10% of our daily requirement. In addition, it might also include energy used for physical activity, particularly for more active patients. Everyone will have a little bit of energy come from physical activity, even if you just are stationary. Though for patients who regularly exercise, they actually generate energy, which is then calculated in our energy expenditure. So basically, all three of these factors add up for our energy expenditure. It is important to note that sometimes the requirements are increased in our sick or injured patients, though it depends on the specific patient population. And we're going to be going through many different patient populations throughout the course of this class. But that's just something important to note, is that our requirements for energy may be increased for sick. How do we calculate energy expenditure, or essentially the total amount of kilocalories that we need per day? There are three different widely used methods. Probably the most commonly used are weight-based equations, and those will be the equations that we actually use more often than not in this class. We will also see predictive equations as well. So basically, these predictive equations are just formulas that are derived for specific patient populations. Sometimes they may be used for wider patient populations, such as healthy patient populations. Though those are not used as commonly as weight-based equations. And then our gold standard is indirect calorimetry to measure energy expenditure. And that's actually what you see on the right side of the screen here with the patient who's strapped to this mask in the machine. Basically, what indirect calorimetry does is it measures the intake of oxygen and the exhalation of CO2. And what that does is it actually goes through and measures the patient's breathing for a certain amount of time. Usually this test, once you get a patient strapped in, takes about less than an hour, sometimes less than 30 minutes to complete. What it does is it measures the O2 and CO2 exchange, and then that will essentially basically generate a number of calories that is basically that patient's energy expenditure. The reason why this can be done is because if you think about our macronutrients, a lot of them are carbon-based or organic, and because of that, whenever we take in macronutrients, a lot of times what happens is that they break down into carbon dioxide and water. And the way that we actually eliminate carbon dioxide in our body is through breathing out. So basically, because we're breathing out carbon dioxide and we breathe in O2, that's why this machine can go through and measure essentially the carbon dioxide, compare with the oxygen that we take in, and actually measure a number using an equation. And so that is essentially what the gold standard is in terms of measuring energy expenditure. Though I will say that indirect calorimetry is not done very much in clinical practice because essentially a machine is involved. Sometimes these machines can be thousands of dollars, as well as the fact that there may be not many people trained to use these machines. Anybody can utilize these machines and figure out how to use them to assess energy requirements. However, just in general practice, we will probably use weight-based equations or predictive equations more. However, indirect calorimetry is the gold standard and the most accurate way of measuring energy expenditure in a majority of our patients. And we'll talk about this a little more later in the class. So going back to the different types of ways that we can measure energy, one way is weight-based equations. So you see here are a variety of different weight-based equations that are basically simply based off the patient's kilograms of weight. So if you have a patient who's healthy, normal nutritional status, and minimal illness severity, and this can even include patients who are not very sick or just mildly sick who may be in the hospital, who are not in the intensive care unit. These patients will typically require between 20 and 30 kilocalories per kilo actual body weight per day. That requirement changes slightly, though, whenever we look at critically ill patients. So like I said earlier, critically ill patients or patients who are severely sick may require an increased calorie requirement. So in that case, it is actually at the top end of that 20 to 30 range. It's actually 25 to 30 kilocalories per kilo of actual body weight for patients who are critically ill. And critically ill also is the same as metabolic stress in this case for our purposes. So those patients will receive 25 to 30 kilocalories per kilo of actual body weight per day. Make sure that you are aware that this is actual body weight. This does not have the same rule of switching to ideal body weight. In patients who have who are critically ill and have a BMI greater than or equal to 30 or less than or equal to 50, that changes to 11 to 14 kilocalories per kilo actual body weight. For patients who are critically ill and have a BMI greater than 50, that will convert to 22 to 25 kilocalories per kilo ideal body weight per day. And in patients who have major burn injuries, particularly those that have greater than 50% of their body surface area burned, patients may require greater than or equal to 30 kilocalories per kilo per day, for purposes that they are extremely catabolic and breaking down a lot of energy. So as I mentioned before, predictive equations are essentially equations derived for specific patient populations. There are many different predictive equations out there. There are actually hundreds to thousands of different predictive equations out there, depending on the different patient populations that you may see out there. Now, in terms of this slide, I don't want you to memorize any of the equations on the right, as these equations are pretty complex. And a lot of them have actually been derived as a result of linear regression models. I will give you an example, though, that for the Harris-Benedict equation, Harris-Benedict is actually best utilized in patients who are healthy, so patients who are not ill. Other examples of predictive equations include Mifflin-St. Penn State, Aretin-Jones is another one you may hear of, that are relatively common. For our purposes, you don't need to memorize any of the particular equations, but just be familiar with the names. Just know that Harris-Benedict, Mifflin-St. and Penn State are examples of predictive equations. Now that we've talked about macronutrients and macronutrient requirements, particularly with protein, fat, carbs, and calories, now we're going to transition and talk a little bit about micronutrient requirements and micronutrients in general. So micronutrients, again, include our electrolytes, trace elements, and vitamins. And for the purposes of this class today, we're focusing mainly on trace elements and vitamins. We're actually going to be talking about electrolytes in a few class periods whenever we discuss sodium, potassium, magnesium, phosphorus, and calcium homeostasis. So we'll start off with trace elements today. So in regards to trace elements, if you remember what we talked about earlier, trace elements are essentially elements that are typically found in very trace or small amounts that we actually need for consumption in the body. So examples of these are chromium, copper, iron, manganese, selenium, and zinc. And you actually see here on the periodic table on the right that a majority of these are actually included within our different transition metals or transition elements. The only one that is not is selenium, which is in group 6A, as you see on the right. Selenium is a non-metal, so that's very important to note that not all trace elements are necessarily metals. Another example of another trace element that's common, but we're not going to talk about it here, is iodine. And typically we find that in products such as salt or sodium chloride that's found basically in a lot of your different foods out in the real world. But we're not going to necessarily talk about iodine today. We're just going to focus on specific trace elements, as there are many trace elements out there. The first trace element we're going to talk about is chromium. Chromium is required for glucose and lipid metabolism, and it potentiates the action of insulin. As a result, some diabetic patients will actually use chromium as a supplement to improve their diabetes. In regards to deficiency for chromium, deficiency is very rare for chromium specifically, but it may be associated with patients who receive massive bowel surgery and are placed on parenteral nutrition without proper supplementation. So if they get a massive bowel surgery and for some reason we don't have chromium available as a trace element, or we don't have a multi-trace or other trace element combination product available, those patients would probably be at the highest risk of a chromium deficiency. Dietary sources of chromium include whole grains, egg yolks, beer, processed meats, mushrooms, and legumes. The next trace element we will discuss is copper. Copper mainly functions in oxidation and reduction reactions and electron transfer reactions involving oxygen, such as cytochrome C oxidase, and you don't necessarily need to know the name of that enzyme. Just know that it functions in oxidation and reduction reactions and electron transfer reactions. It is also involved in cholesterol and glucose metabolism. Deficiencies related to malabsorptive disorders like celiac disease, where patients may be particularly sensitive to gluten. It may also be related to patients who get any bariatric or intestinal surgeries, as well as undernutrition associated with chronic diarrhea. Copper toxicity is very rare and very uncommon, though some patients with particular genetic disorders such as Wilson's disease may actually accumulate copper, and it might actually cause multi-organ failure. Though Wilson's disease is very rare, it's still important to know about. Dietary sources of copper include liver, cocoa, beans, nuts, whole grains, and dried fruits. Iron is another important trace element that is commonly seen and plays a role in a lot of different areas in our body. It's an essential component of hemoglobin, myoglobin, and cytochrome. So it essentially helps more or less in the structure of blood cells or red blood cells. Iron also reduces free radical production and oxidative damage to membranes. Deficiency of iron is particularly associated with women of childbearing age, so that's why you might see some women not only just on folic acid supplements, but some women may also be on supplements containing iron, particularly if they are trying to conceive or if they are pregnant. Deficiency is also associated with patients who have excessive blood loss, or excessive blood testing performed while in the hospital. So if they lose a lot of blood, obviously blood contains iron as part of the blood. And whenever you lose blood, you lose iron. If you have a lot of blood testing that is done within the hospital on a patient, that can also result in iron deficiency as well. Malabsorptive disorders may also be associated with iron deficiency, such as celiac disease and Crohn's, GI surgery, and an important one is decreased stomach acid production, because iron absorption is highly mediated by stomach acid. Stomach acid helps iron absorb. So as a result, any medication that affects stomach acid or reduces the production of stomach acid will basically minimize the absorption of iron. So think about your antacids, your H2 antagonists, such as famotidine, ranitidine, or Pepsid, as well as proton pump inhibitors, such as pantoprazole, esomeprazole, omeprazole. Basically, anything that will affect stomach acid will affect the absorption of iron. Deficiency may result in microcytic anemia. So if you remember microcytic anemia, whenever you talked about anemia previously in your therapeutics modules, microcytic anemia hallmark is basically a mean corpuscular volume of less than 80 with concomitant anemia. Iron overload may result in hemochromatosis, which is essentially just iron overload, or a fancier name for iron overload. And dietary sources include meats, seafood, broccoli, peas, bran, and enriched breads. Manganese is another trace element that's relatively common. It's a constituent of various metalloenzymes and an activator of certain enzymes. Manganese deficiency is very rare. Um, However, toxicity is relatively common only in our long-term home PN patients and patients with hepatobiliary disease. Manganese is eliminated primarily hepatically, and as a result, patients who have different types of liver disease, such as cholestatic liver disease, for example, may actually have accumulation of manganese. So this is not necessarily common for the overall population. It is common in long-term home parenteral nutrition patients. Up to 50% of them may have some kind of signs of manganese toxicity, particularly if they have gotten PN for chronic periods of time, as a lot of the PN ingredients actually have manganese contamination associated with them. And this contamination can actually, in the home care population or the home PN population, result in cerebral and hepatic complications. Dietary sources include nuts, oats, and other whole grains. And only about 1 to 5% of manganese that we consume in the diet is absorbed. As a result, that's why we typically, for normal patients, don't see toxicity very much. Though in our chronic home PN patients who basically get manganese through a variety of different ingredients in the parenteral nutrition formula, actually may get manganese toxicity. So it's important to note that it's relatively not well absorbed, and as a result, you don't have toxicity in a majority of normal patients. As we mentioned earlier, selenium is our trace element that is a non-metal that we're talking about today. It's required as a cofactor in glutathione, iodine, and thyroid metabolism. Deficiency is associated with trauma, as well as statins. Remember, statins are HMG-CoA reductase inhibitors. And the reason why statins actually cause a deficiency is that they interfere with the production of the selenium storage proteins called selenoproteins that actually hold selenium and carry selenium throughout the body. So basically, if those selenium proteins are not made, then essentially you can develop a deficiency, and statins actually interfere with that process. In addition to the fact that statins lower cholesterol. So that's just a little fun fact about statins. Dietary sources include fish, meat, eggs, milk, and shellfish. Zinc is a very important trace element. It's a catalyst for many different enzyme reactions, and it serves as a structural function in metalloenzymes and in proteins. So if you see to the right here, this is actually the structure of a rather large protein. And zinc essentially is kind of holding together, you see the cysteine and the histidine moieties here. And essentially what we refer to this as is zinc finger motif or zinc finger proteins. Zinc is also a regulator of gene expression involved in lipid peroxidation, apoptosis, neuromodulation, cellular proliferation, differentiation, wound healing, which is a major one, glucose control, and immune function. So anytime a patient has a major wound or is sick, zinc may actually benefit them. Deficiency is associated with alcoholism, patients who are post-op, patients who have severe burns who are already potentially immunity compromised or immunocompromised, patients that have wounds because these wounds can actually leak a lot of zinc, as well as GI losses such as GI losses that you get from fistula, or essentially what fistulas are known as are essentially more or less disconnections in the GI tract or little holes that cause leakage. And those leakages can actually leak out a lot of zinc. So if a patient has some type of fistula, they may actually require a higher amount of zinc in their diet. Patients who have malabsorptive disease, particularly after intestinal bypass or resection, malignancy, liver disease, and renal disease. Dietary sources include seafood, meats, greens, and whole grains. In total, of the primary trace elements that we have, this is a listing of our daily trace element requirements for patients. You note that it's not bolded here for 5 out of the 6 trace elements. Therefore, you do not necessarily need to know these numbers off the top of your head. It is important to note, though, that for iron, iron is not typically added to a lot of our trace element formulations that we have out there for parental nutrition. And the reason why that is iron can actually cause fat emulsion in a parental nutrition formulation to what we call crack or become unstable. As a result, the fat emulsion can actually re-separate out into its separate layers and not be stable to administer to a patient. So typically, we don't see iron added to IV trace element formulations except for ADAML-N, which is a trace element formulation that's pretty popular in Europe and has been brought over to the United States, particularly in times of multi-trace element formulation shortages. So like I said, we do have a few common IV formulations for trace elements. One of them is multi-trace 5 or MTE5, and it's provided as 1 ml typically, as well as ADAML-N that I just mentioned before, which contains iron. In patients who have hepatic elimination concerns, particularly those who have cirrhosis, copper and manganese are eliminated via hepatic elimination. So, whenever you have a patient that either has liver disease or some kind of hepatobiliary elimination issue, particularly if your total bilirubin level is greater than or equal to 2, you may consider reducing trace elements in a parenteral nutrition bag. That part is important to note. So instead of giving them the 1 milliliter of multi-trace that they would typically get every day for trace elements, you may give them half a mil or even no trace elements, and then replace the remaining other trace elements that are not going to be in excess individually with individual products such as individual zinc, selenium, chromium. It just depends on what you have available to you and what you feel comfortable with for your patient. A lot of times, toxicities will not occur with trace elements unless they are being given chronically, particularly for longer periods of time, like greater than 1 month or even more than that months, such as what we see in the home care setting. The trace element reduction is not something that is hard and fast in guidelines, and a lot of different experts debate about this. But for the purposes of this class, we're going to consider reducing trace element allotment for any total bilirubin that is greater than or equal to 2. In regards to renal elimination, zinc, selenium, and chromium are specifically affected via renal elimination, though it's really a lower concern in patients who have renal failure, because a lot of times patients who have renal failure that is significant to cause these toxicities will be on renal replacement therapy, such as hemodialysis or peritoneal dialysis, where essentially these elements will be taken off. Though we may still, potentially see some toxicities out in practice chronically. So now that we've talked about trace elements, now it's time to transition to vitamins. So vitamins are typically provided to all patients daily in either enteral or parenteral nutrition, except if vitamins are in shortage or if a patient has hypervitaminosis, which is essentially a state where the level of vitamin in the body is too high for a certain vitamin. Or common vitamin formulations are multivitamin infusion, multivitamin or MVI 12 or MVI 13. what is the difference between MVI-12 and MVI-13 is that MVI-13 contains phytonadione or phyloquinone, which is actually vitamin K, depending on which formulation of it that you actually get. Multivitamin infusion 12 or MVI-12 does not have vitamin K in it. And that's a very important point to note, especially if you have patients who are on nutrition support who are receiving warfarin, because vitamin K can obviously affect our INR, our therapeutic parameter to measure warfarin efficacy. Multivitamin infusion is typically provided as 10 milliliters per day, and that's standard for all patients. Infuvit is another vitamin that is out there. It's not commonly seen as much. Mostly we see MVI or multivitamin infusion in practice here in America. Multivitamin formulations will make PN appear yellow. Another common example of this is the fact that whenever a patient comes in with potential alcohol use or alcohol withdrawal, they will get what's called a banana bag. And the fact of the matter is that banana bags actually contain this same multivitamin infusion or MVI. And that's why banana bags get their yellow color is from multivitamin formulations or MVI. Vitamins are divided into water-soluble vitamins and fat-soluble vitamins. The fat-soluble vitamins are A, D, E, and K, or also known as ADEC. Water-soluble vitamins are divided into vitamins B and C, with vitamin B having many different subtypes that we will discuss. Vitamin A, to start off with, represents a subgroup of compounds known as retinoids. And vitamin A can exist as retinol, retinaldehyde, retinal, or retinoic acid. For the purposes of the naming of these different vitamins, I want you just to be familiar with what the vitamin name is. So vitamin A, for example, as well as what the root name of its other forms are. So in this case, I would expect you to know retin is basically a form of vitamin A. Say if I would give you that on an exam. It functions in use of appropriate vision, normal reproduction, bone development, immune function, and epithelial cell differentiation. Particularly, the one that we know it most for is for vision. Elevated serum levels are associated with renal disease, and the binding capacity of our retinol binding protein is exceeded. Deficiency is associated with fat malabsorption as well as pregnancy. The reason why its deficiency is related to fat malabsorption is because vitamin A is fat soluble. You have to think like dissolves like, essentially. So if you don't have a lot of fat absorption occurring, then in that case there's not a lot of fat being absorbed that has vitamin A basically dissolved in it. Therefore, you won't actually get a lot of actual absorption of vitamin A if you have fat malabsorption. And that goes essentially with all of our different fat-soluble vitamins: vitamin A, vitamin D, vitamin E, and vitamin K. Dietary sources of vitamin A include liver, fortified milk, eggs, dark green vegetables, and yellow-orange vegetables. The one I typically think about is carrots, particularly. The next vitamin we'll talk about is vitamin D. It's probably one of the most common known vitamins that we know of, particularly in practice. So vitamin D can refer to a variety of different subtypes. It can be referred to as ergocalciferol in the vitamin D2 form, which is consumed in the diet, or cholecalciferol, which is vitamin D3, which is synthesized in the skin post-exposure to either solar or ultraviolet light that is artificial. So essentially, vitamin D, a majority of vitamin D that we actually consume can actually be from sunlight. If you spend, anywhere between 10 and 15 minutes outside every day, you actually will have your daily amount of vitamin D taken in. Now, obviously, it's still important to supplement in the event that you don't have a lot of sunlight exposure, say for people who live higher up north, such as those who live like in the Arctic Circle who don't have consistent amounts of daylight every day. It might be important for them to supplement themselves. Um, Functions include calcium and phosphorus homeostasis, um, which increases intestinal absorption and bone resorption, neuromuscular function, and bone calcification. Vitamin D has some pleiotropic effects or pleiotropic effects important for musculoskeletal disorders, falls, immunity, infection, cancer, diabetes, and cardiovascular disease. So whenever we talk about its functioning in calcium and phosphorus homeostasis, the one thing that we think of is bone, particularly. It increases the intestinal absorption of calcium, as well as enhances bone resorption as well. So that's an important point to note. Deficiency is associated with extensive skin damage, so if that skin cannot properly absorb sunlight and get vitamin D, then in that case, you might have to orally or IV supplement. People who wear clothing that exposes little skin or who stay indoors much of the time obviously may have vitamin D deficiency because they are not basically getting vitamin D from the sunlight. Again, deficiency can be related to fat malabsorption because vitamin D is a fat soluble vitamin. Renal disease can also be a source of vitamin D deficiency because then you will not be able to produce calcitriol. And in patients who get long term parenteral nutrition administration, the vitamin D in the vitamin formula for parenteral nutrition, the multivitamin, may not be enough for a majority of patients, even despite oral vitamin D supplementation. Dietary sources include fish liver oils, fatty fish, fortified milk, which I think is really the biggest example, in my opinion, and breakfast cereals. And as we mentioned, sunlight is an important component of vitamin D exposure and vitamin D source. Vitamin E is a naturally occurring that has activity, and basically its subtypes are called tocopherols and tocotrienols. Functions include antioxidant activity, so essentially maintenance of membrane integrity, inhibition of cell proliferation, platelet aggregation, and monocyte adhesion. It may have some anti-inflammatory, anti-neoplastic, and natriuretic properties, though some of these are not very well studied. Deficiency of vitamin E is actually very rare. One thing that is important, though, to note about vitamin E is that it may interact with vitamin K, and that can be problematic for patients who are on warfarin therapy who want to take vitamin E. Dietary sources include vegetable oils, wheat germ, asparagus, and peanuts. Vitamin K is another common vitamin that we see out in clinical practice. It's a family of compounds that contains phytoquinones or phytonadione, which is also known as vitamin K1. One of the most common functions that is known about vitamin K is its role in blood coagulation or clotting. As you see the coagulation cascade on the right. And that coagulation cascade actually is involved in the activation of different factors that will actually produce a clot. And basically, vitamin K is more or less a cofactor that helps in the activation of factors 2, 7, 9, and 10, as well as the anticoagulant proteins C and S. It also functions in bone health as well. It's not traditionally included in injectable MVI-12 formulations, as we mentioned before, though it is included in MVI-13. Important note there, hint, hint, star, star. And it is an antidote, obviously, for warfarin toxicity. Deficiency is associated again with fat malabsorption because it is a fat soluble vitamin, IBD, and antibiotic therapy. Dietary sources include green leafy vegetables, liver, broccoli, peas, and green beans. Another source is actually fat emulsion. Fat emulsion, such as intralipid, actually contains vitamin K, which can be a little bit problematic whenever you have a patient on PN and warfarin at the same time. That fat emulsion or the fat emulsion amount that you give to a patient can actually affect the patient's INR, and it might require you to change the patient's warfarin dose while you have the patient on parenteral nutrition. So it's important to keep vitamin K content consistent while you're on warfarin, as this can vary the INR significantly. Vitamin C is typically available as ascorbic acid, the reduced form, or dehydroascorbic acid, which is the oxidized form. Transport systems for vitamin C are saturable and dose dependent, and there are a few toxic effects seen with vitamin C. Vitamin C differs from the other vitamins we've talked about so far in that it's water soluble. That's why we will not see as many toxicity reactions compared to the other vitamins that are fat soluble. Serves as an antioxidant and in roles related to the immune mediated and antibacterial functions of white blood cells. Deficiency and eventually scurvy, which is pretty rare, are related to malabsorptive disorders. Poor diets combined with alcoholism, type 2 diabetes, certain cancers, surgery, severe burns, and smoking. Again, scurvy is very, very rare. You only need minimal amounts of vitamin C in your diet to basically avoid scurvy. Dietary sources include citrus fruits and other fruits and vegetables, so things like oranges, tangerines, etc., have vitamin C in plentiful amounts. Thiamine is also known as vitamin B1, and it exists as a few different forms: thiamine monophosphate or TMP, thiamine triphosphate or TTP, and thiamine pyrophosphate TPP. Thiamine serves roles in energy transformation and synthesis of pentoses and NADPH and membrane nerve conduction. The most common reason for patients to be deficient in thiamine is alcohol abuse. Um, in patients that have alcohol abuse, the thiamine absorption is impaired, and patients can become deficient in thiamine, and that can eventually result in Wernicke's encephalopathy, where essentially they get ultramental status, ataxia, etc. So it's important for particularly patients who have an alcohol history to receive thiamine. Other reasons for deficiency include hyperemesis gravidarum, which is a state during pregnancy where a pregnant patient may be throwing up significantly. In those cases, you might need to supplement a patient with thiamine, as well as breastfeeding syndrome. Dietary sources include enriched fortified whole grains, pork products, sunflower seeds, and wheat germ. Riboflavin is also known as B2, and the thing to know about it is it's essentially just the precursor to FMN, or flavin mononucleotide, and flavin adenine dinucleotide, or FAD. So if you think FADH or FAD, essentially these are involved in energy production. So essentially, riboflavin serves as an intermediary for oxidation reduction reactions, donating electrons to the electron transport chain for ATP production. Riboflavin deficiencies associated with alcoholism, thyroid disorders, and type 2 diabetes, extreme stress, and chronic malabsorptive disorders. Its dietary sources are organ meats, milk, bread products, and fortified cereals. Niacin is known as B3. Its two active forms are nicotinic acid and nicotinamide. The important things to know about niacin is that it serves as a component of NAD and NADP, or nicotinamide adenosine dinucleotide and nicotinamide adenosine dinucleotide phosphate, or NADP. So it also serves as an intermediary for hydrogen donation or electron acceptance. Um, Niacin is used in some patients who have hyperlipidemia as a treatment, though it's not really generally recommended as first line in guidelines, though it can lower some different lipid parameters. One thing that niacin does cause is flushing, so it may be beneficial to tell your patient taking niacin to take a full strength 325 milligram aspirin 30 minutes before taking niacin to minimize flushing. Niacin deficiency is pretty rare in industrialized countries. However, in more third world countries, niacin deficiency can eventually result in what's called pellagra. And pellagra is characterized by 3Ds: dermatitis, diarrhea, and dementia. Again, it's pretty rare. It doesn't really happen much in industrialized countries, more so in countries that are not as well developed. Dietary sources of niacin include meat, fish, poultry, enriched in fortified breads, and fortified cereals. Pyridoxine is also known as vitamin B6 and also exists as pyridoxal and pyridoxamine. It participates in over 100 enzymatic reactions, including protein, amino acid, and lipid metabolism, gluconeogenesis, steroid receptor binding, CNS development, neurotransmitter synthesis, heme biosynthesis, and normal immune function. In regards to pharmacy, probably one of the most key things to know about in clinical practice about pyridoxine is that isoniazid usage, which is one of the first line medications in the treatment regimen for tuberculosis, may be associated with deficiency. So if you have a patient who is starting isoniazid, I would recommend that they also start pyridoxine supplementation at the same time. That's very important clinically. Dietary sources include fortified cereals, organ meats, and whole grains. Cyanocobalamin, or cobalamin as it may be called in some other references, is also known as vitamin B12. That's why essentially the parentheses is placed in the title line there, because it can be referred to as cobalamin as well. Active forms include methylcobalamin, hydroxyl cobalamin, and deoxyadenylyl cobalamin. One thing that's unique about vitamin B12 is its absorption. The oral form requires binding to intrinsic factor, which is secreted via the gastric parietal cells, or basically the parietal cells in the stomach. And then basically once that oral form of vitamin B12 binds to intrinsic factor in the stomach, it is then absorbed later on in the GI tract in the ileum. Vitamin B12 also plays a role in the activation of folic acid. So because of its specific binding to intrinsic factor and its absorption in the ileum specifically, any kind of agents that reduce acid production from parietal cells, such as like H2 blockers, proton pump inhibitors, like antacids, for example, even, as well as other agents such as excessive vitamin C and metformin, can all cause decreased bioavailability of vitamin D12 and then subsequent deficiency. So vitamin B12 is one vitamin that's actually pretty heavily regulated by the types of medications that patients can be on. And H2 blockers, proton pump inhibitors, and metformin are very common out in practice. We also may see Crohn's disease and gastric resection being a cause of reduction of bioavailability of B12. The reason why gastric resection is important is because if you have a gastric resection, then in that case you won't have as much intrinsic factor produced by the stomach. And if you don't have as much intrinsic factor produced, that vitamin B12 won't be able to bind to as much intrinsic factor to eventually be absorbed in the ileum. So patients who have any kind of gastric resection may need vitamin B supplementation on the side. particularly maybe via a parenteral form such as IV. Its deficiency may result in macrocytic anemia, similar to folic acid, which we'll talk about in a moment. Dietary sources of vitamin B12 include fortified cereals, meat, fish, poultry, and eggs. Folic acid is also known as pteryl glutamate, pteryl monoglutamate, or vitamin B9. It serves as a coenzyme in the transfer of carbon from one compound to another for amino acid synthesis and nucleic acid synthesis. It's important to note that the deficiency or folic acid deficiency is associated with alcoholism. So whenever we have a patient come in with alcohol history or alcohol withdrawal potentially, a lot of times what we'll do is we'll actually start them on a banana bag, and as well as thiamine supplementation and folic acid supplementation or folate supplementation. Deficiency is also associated with pregnancy. So a lot of times in pregnancy, you will see patients require a folic acid supplement. And in addition, medications may cause deficiency of folic acid, such as carbamazepine, estrogen, and then other anti-epileptics such as phenobarbital and phenytoin. In those cases, those patients may actually require an increased dose of folic acid compared to the normal recommended dose for pregnant women. Like vitamin B12, deficiency of folic acid can result in a macrocytic anemia. Macrocytic anemia is characterized by a mean corpuscular volume, or MCV, of greater than 100. And the dietary sources include enriched cereal grains, dark green leafy vegetables, and fortified cereals. We talked a lot about different macronutrient and micronutrient deficiencies today, and a few toxicities. I'm going to refer you to an appendix from our nutrition focused physical exam book via Aspen that will show you what some of these physical exam findings actually look like. It's important to note that it's just important to be aware of what these findings look like. I'm not necessarily going to test you on the exam and throw a picture up of what one of these deficiencies look like and ask you what deficiency or toxicity it is. However, I do want you to take a look at that appendix just to get an idea of what some of these deficiencies and toxicities can actually result in, because obviously it can be very harmful and detrimental to our patients. In addition, I do want you to watch another video on physical exam. This video is about like 9 minutes long. It's also from UNF on how to do a micronutrient physical exam. So if you remember last week, they did a general physical exam that you watched on YouTube. This one is a micronutrient physical exam. So basically looking at things like hair, skin, nails, as well as the orofacial region to detect any kind of micronutrient, and in some cases, some macronutrient related physical exam findings that you may see regarding your patient. Here are the references for today's talk. If you have any questions regarding macronutrient vitamins and trace elements, feel free to contact me at my email. Thank you and have a great day.